So another section that they revised and added a fair amount to is
What's going on, everybody? Welcome back to another episode of the Core Consults RX podcast. Tonight, this is actually a special request episode because one of my coworkers, Dr. Starr, I won't give her last name, but I'm sure she wouldn't care, but just in case, she asked me if we would talk about the new and improved American Diabetes Association guidelines from 2021, and I told her, sure.
Sure.
And so this is, we've gotten a few suggestions recently, but this is a friend of mine, so I had to move her to the top of the list. She's somebody I work with, so got to help my homies out first.
Is it improved? I guess we'll find out.
We'll see.
It's new. Guess. There's some improvements, and then there's some
stuff.
It's all fine.
I don't necessarily agree with. We'll talk about it.
We'll talk about it.
But yes, so that's that. We'll get into that stuff. It's February. Winter is in full swing, apparently.
Yeah, I had to pull out a snowplow to get here.
Did you?
No, we're not in Texas. But, there's apparently something. Well, we're not going to get any snow. But the whole thing's coming this way,
Yeah, it's definitely, I don't know. We got snow that one a couple of years back. It was ridiculous.
Yeah, I feel bad for the people in Texas. It's just
nobody there has a clue, how to, not only, they're like here, we don't know how to drive in it.
Exactly like if we got hit with a similar storm, we would be in.
The whole city shuts down.
Yeah, the whole thing shuts down.
Nobody has a clue what to do. Nobody has anything prepared.
But then they have the power outages too.
Mm-hmm.
Man.
Yeah.
It was 64 in my house last night and I was freezing.
Yeah. Kind of like what it always is in my house.
I know. You got the dog.
We have a big Alaskan Malamute, and he gets hot in 70-degree weather. So
he belongs in Alaska.
Yeah, it's probably true. I didn't feel bad bringing him all the way down here, but we have to keep our house ridiculously cold just for him. He'll go outside now where it's cold for us. He'll go outside and just lay on his back upside down and go to sleep.
He's just perfectly content.
Perfectly content. But so where should we jump in with this? I guess we'll just kind of touch on maybe some of the nuances. Yeah.
So they call the 2021 guideline confusing because it was put out in 2020, but at the end of 2020.
Yeah. I feel like they do that every year, right?
Yeah, I guess they do. Sometimes I feel like it leaks into the actual year.
At least they get a new guideline out as opposed to some of these guidelines.
It's 7 years.
7 years and you don't hear any updates.
Like blood pressure, right?
Yeah.
They take forever.
It's been 2017?
Yeah, they brag right in the first sentence. It's annual update since 1989.
Yeah.
It's good job. That's actually impressive because most do not.
The American Diabetes Association getting cocky.
Doing something right. So if you look at the whole guideline, there's a lot of redundant stuff, right? So there's a lot of things they just leave the same. So usually when something like this comes out, you want to focus on the updates. So updates with this include some pharmacologic updates as far as recommendations around comorbidities like heart failure and CKD. They also put a heavier emphasis on continuous glucose monitoring devices and also just in general improved technology and kind of how to use that in diabetes. And then they also talk about improving care and promoting health in different populations and social determinants of health. So some updates from the last one, but a lot of it is kind of the same.
One thing I noticed that in section 2, which is the classification and diagnosis of diabetes, one thing that was good is they kind of gave more discussion on what's referred to as latent autoimmune diabetes in adults, or LADA. This is something that I personally didn't put much thought into before, but now working at my current job at Fetter, I have seen probably 10 to 20 patients who for years have been listed as a type 2 because they developed diabetes much later in life, and so it's just and they're overweight. They fit the phenotypic description of a type 2 diabetic, so to speak, but for whatever reason they're not. Their blood sugar is just not getting controlled. They meet with the dietitian. They'll be on all the right meds, and their A1C is still high. So we'll get a C-peptide on those patients, and it comes back super, super low. So their bodies aren't even producing insulin anymore. So we would have to treat them like a type 1, and they've been basically not being treated correctly that whole time.
Right.
So that's something that I don't know how often people are running into this, like in your clinics and whatnot, but that is something that 100% you should at least be on the lookout for.
Yeah.
I thought I called one like 2 days ago, but the C-peptide came back today normal. We got a patient who his A1C has only been controlled when she was pregnant and they put her on insulin. Then it got controlled, but she got diabetes shortly after having a really bad bout of pancreatitis. And so we thought, like, no way, her beta cells have been destroyed, all that. And but no, still producing insulin. And so we went ahead and started her on Jardiance instead. But I thought I was going to call it, and I was like, nope, I was wrong. I've had other patients, though, that I'm like, nah, there's no way. This is probably a waste of time. And then it comes back, C-peptide's like 0.1, or like almost undetectable. So make sure you're following up with those types of patients if you see them, because that's much more common, I feel like, than I ever would have guessed.
Yeah, super interesting. Another addition they made was to kind of the prevention and delay of diabetes. So they created a subsection talking about the delivery and dissemination of lifestyle behavior change for diabetes prevention. So it's kind of long-winded, but it's based on the DPP trial, which we know looked at lifestyle intervention and in pre-diabetic patients and how it can delay the progression and how effective that was. So basically, they just give resources like the CDC and various different things. They give information and give you recommendations on how to disseminate that information on lifestyle and behavior change. So, taking some steps towards making sure that patients actually do that, or that you or at least have the resources that you need. They also reference pharmacists. They say other allied health professionals like pharmacists and diabetes care and education specialists also have the capability of delivering lifestyle behavior change programs that may be considered for diabetes prevention efforts.
Ayo.
So thanks for the shout out.
Yeah, especially when those pharmacists also are diabetes educators. When you got that double threat.
Like a humdinger.
Something, yeah, as they say. Another thing that they've mentioned this before, but something that may not be familiar with or may not see very often. If you have a patient who, let's say that their A1C is elevated, but when you look at their glucose levels, it does not reflect that. So their glucose levels in the blood are normal, but you check the A1C, that's really high. They say that basically, in this case that they're talking about, they're assuming you already have a diagnosis, but things that can kind of cause that to happen, like hemoglobinopathies, sickle cell disease, sometimes pregnant patients in their second or third trimesters, patients that have like a glucose 6-phosphate dehydrogenase deficiency, patients that are undergoing hemodialysis, recent blood loss or transfusion, patients that are on erythropoietin therapy, things like that can all raise A1C without incorrectly. Basically, it's not actually reflecting the patient's true glucose levels in the serum. So in those patients, they say that you need to make sure that you're using the plasma blood glucose criteria for diagnosis and not the A1C. And also, too, if you have a patient who's all of a sudden their A1C comes back really high, but their glucose isn't reflecting that, then maybe it'd be a good idea to do some further evaluation, some differential diagnosis to try and figure out maybe what's going on. I had an older physician quiz me on that one time with the hemoglobinopathy.
Yeah.
I got that part.
Did you nail it?
I got that part right, but then I'm glad he didn't go further because I couldn't tell you much about it.
See, I've never been very good at the whole pimping thing. When they ask you the questions, I mean, I can generally answer some, but it's always like I'm just like, oh, I don't know, and then a couple minutes later, I'm like, dang, I knew that answer. I just remember now. So
if you guys are looking for a soundbite to steal from the show, just get Cole saying, I've never been really good at the whole pimping thing. And then just send it to everyone you know.
That's what they call it, right?
It is what they call it.
Though we never did in pharmacy school. I think it was like a med school thing.
On rotations, you never did?
That's not how I just called it like them asking me questions, unless I just didn't know the cool lingo.
I'm going to say, I think you just didn't know that. Cause I think asking you questions is basically what pimping is.
No, I know that's what it is. I just didn't call it pimping.
Oh, I didn't. Yeah, I was going to say.
I thought that referenced illegal behavior.
Well, depends on what state you're in, I guess.
What is that called? An allegory?
Something like that.
Or am I forgetting 9th grade English?
It's an onomatopoeia. I'm just kidding. I know it's not that. It's just a funny word to say.
Throwing things out. It's a soliloquy.
Gosh. All right. What are we talking about? Diabetes? Right on.
Right.
I'm gonna definitely steal that sound clip later.
Yeah. Send it to my mom.
Yeah. Look at your son. So what else is different?
One thing they added, which is I think more relevant to this year, is they added kind of a whole section on immunizations, which they usually reference, of course, but they made a nice table, which is pretty much a copy and paste of the CDC guidelines for immunizations, though they give the updated kind of PCV 13 recommendation about it being, kind of shared decision making and all that. I think that was, man, 2020 flew by. That might have been a 2019.
It was, yeah.
So it might have been in the last one, but they mentioned it in this one too. So
I watched the ACIP meeting live, because we've been talking about how garbage PCV 13 is for anyone over 65, regardless of comorbidities. We've been talking about that study for a minute now, and since I was the first time I heard it, I guess Dr. Word talked about it too, but I remember you presenting on it when I was on your rotation, so that must have been 2017. Yeah, almost at 14. I wasn't even a pharmacist then. I'm such an idiot.
That was when you were on rotation.
Yeah, that's when I was on rotation.
Yeah, 2017. I remember you presenting it at, to the group of pharmacists.
But yeah, it's one of the. Oh, that's right. That's the same. That's the same.
I took a road trip with you to Columbia.
That's right, because that was the same day that I was making fun of Prevnar and didn't realize the two people in the front row were Prevnar reps.
Prevnar reps.
Oh, they were probably not happy. But oh well. Thanks for the free lunch. Sorry about that, guys. No, I remember the person that was putting the thing was like, the people you were just sitting directly in front of you while you're talking with the Prevnar reps. I was like,
well, because I think they literally came and started speaking after you.
Yeah,
I'm pretty because we
like,
stayed.
Let's talk about Prevnar.
Yeah, it was like right after they started talking about
it. Belittled it. Like
I think
crazy.
I realized that it was very uncomfortable because I barely remember what they said. I just remember being very uncomfortable the whole time they were talking, because I was like, this is like opposite of what Mike just said.
Yeah, I thought it was hysterical. Because I saw people looking around like, wait a minute.
All these new grad pharmacists are like, what?
And if you don't,
so what do we do?
If you're not familiar with it, it's because it takes, in order to prevent one case of community-acquired pneumonia that I could treat with like a Z-Pack potentially, you have to treat 1,000 patients with the vaccine if they're 65 and over. And so there's a whole bunch of stuff that was garbage about the trial. But my whole point of that was, I remember watching the ACIP meeting where the guy from Pfizer, I guess he was like one of their top guys. I don't think he was a CEO, but whoever it was, a high-level guy, was just like, no, wait a minute. We have good outcome data. And he was like arguing that people were like, hey, no, we've had zero changes in occurrence of pneumonia. We're not going to... You got your billions of dollars.
Which, don't they have some more pneumonia vaccines in the pike anyway?
There's a 20 serotype and a 15 serotype in the pipeline that are both conjugate vaccines. So we'll see.
So like PCV13?
Yeah. I think one of them, Pfizer's the 20.
Pfizer's the 20. Mm-hmm. So it'll just take,
it'll
take
take
PCV13's place.
Yeah. Be interesting.
Well, be excited to see that data.
Yeah. Anyways. That people are now the ones that complain about us going on tangents. Like,
well, that was a relevant tangent.
Yeah. See,
relevant.
Thank you, Cole.
Yeah,
Appreciate
immunizations.
Yes,
they're in there.
They're in there. Copy and pasted. One other thing that they do mention that I feel like they kind of touched on this last year, but maybe not, is the A1C goals. So a couple of them. Some slight modifications, like I say that hesitantly because I'd have to go back and look, because I thought they mentioned this last year too. But when we typically think of like the ADA's guidelines for A1C, the typical answer you hear, especially from like students and things like that, is goal of less than 7. Non-pregnant adult patients less than 7. The ADA does say as long as they don't have significant hypoglycemia, that's kind of the main goal for most patients. One thing that they mentioned this time is that if you're using like ambulatory glucose profiles or glucose management indicators, that you should assess like basically the time in range and the time below range to make sure that the time, basically the in range should be greater than 70%, and then like below range should be less than 4%. So you definitely don't want to be having hypoglycemia, and you want to hopefully have them in the correct range. So typically like fasting like 80 to 130 kind of thing for 70% of the time or more. But one thing that they also mentioned this time is that the less stringent A1C goals. So I think we've talked about this a few other times from other guidelines and whatnot, but they do say that a goal like is the example of less than 8% may be appropriate for patients that either have a limited life expectancy or patients that have, they have side effects or harms, basically hypoglycemia from the treatments, and the risk of that is greater than the benefit. So if the way I personally kind of think about it, because I like what the American College of Physicians even says, if a patient doesn't have a 10-year, I think it's a 10-year life expectancy, they don't even give a goal. They basically just say treat to symptom relief and then go from there. So me personally, if I have an older patient, especially if they have a bunch of comorbidities, again, this is just my opinion, I make my first goal with the patient because I want to give them steps that they can kind of reach. My first goal is to get them less than 9 because that's most of my patients are like in the teens. So for them, less than 9 is a big jump or a big drop. And then from there, once they get there, as long as they're not having hypoglycemia and things like that, then I'll try to push them either to below 8 or below 7, depending on their age and comorbidities and all that. But I do kind of start them off with, hey, let's get below 9. That's our first big milestone. And then kind of use that as a platform to start with. But I have patients that are like, in their late 80s that I'm like, there's no reason for me to push their A1C lower.
It's kind of like there was a patient that I saw who was very old and probably had a less than 5-year life expectancy. And she was paying like $500 for Januvia. And I was like, there's got to be something better we can do about this. Whether you're getting enough benefit for it to really matter from Januvia / it's so expensive. Like that just doesn't, I didn't really like that.
Yeah.
But on the other hand, they also talk about more strict goals, which I thought was interesting, which we don't tend to agree with. But the goal they give for general population is 7, but they say it's reasonable to consider less than 7 for patients who aren't having hypoglycemia or aren't having side effects, and if they want to pursue that. In general, we would disagree, though I would say, I guess, if they don't require any medicine, then sure, they're just doing lifestyle on a keto, but just don't, I wouldn't add on medicine or try to treat to push it down lower.
So, and that's actually what I tell patients too when they ask me if they're going to be on medication forever. I always tell them, one, I can't for sure predict that one way or the other, but what I tell them is like the lowest I want to get your A1C is to like right around 7 with medication. Right. Now, if you come back and your A1C, I haven't changed your medication, all of a sudden your A1C is at 6. That's when I know when it starts falling below that 7 mark. That's when I know that, okay, maybe I need to start backing down on the medication so that I don't cause them to have hypoglycemia.
Right.
I had a patient that came back for her second follow-up after reaching goal. Her A1C was a 5.6, I think. And so I'm like, technically speaking, it's like on paper, she doesn't even have diabetes. So I literally stopped everything except 1 dose of metformin a day just for like the long-term benefits of it. But she was on Trulicity and she was on other things, but she made so many diet and lifestyle changes. It's like, I'm not going to keep her on those meds.
And you definitely can. Because, diabetes is not curable, as in you can like regenerate beta cells and stuff. But
for type 2, where it's just become
bariatric
insulin,
surgery, for instance,
is a cure.
Can be a cure for diabetes,
especially type 2, obviously.
So similarly, I suppose lifestyle can definitely make it to where you could come off almost all, if not all, medication if you get it low enough, for sure. Because if you're not on medication, go as low as you want. You know?
Yeah. Within reason, I guess.
Yeah, right. Go to 2.
Why not?
Don't go to 2.
You don't need any sugar. But so if you're wondering like why there's the discrepancy there, if you look back at some of the studies that have looked at some of the A1C goals and things like that, they've done several like head-to-head studies with more strict goal versus relaxed goals. The one I always think about is the Accord trial. So Accord basically took patients, and I think the more relaxed goal got to like a 7.5, I believe, and then the more strict goal I think got down to a 6.4. They actually saw a higher chance of mortality in the more strict guidelines. And their initial goal, I think, was 6, but they didn't even get there. They got 6.4, I think, was the average. I may be off a little bit on those numbers, but
I think
pretty
6.4
sure that's right.
was, they were shooting for 6, they got to 6.4.
Okay, cool. So, in that 6.4 is, there's several patients that I've seen that would meet that criteria, and they actually had a higher chance of mortality, and most of the mortality was stemming from hypoglycemia type issues.
Right, and the drugs they were using at that time
right.
were risky drugs.
more risky to cause that kind of thing.
Yeah.
So, but it was one of those things that, because we didn't see not only any benefit, but we also saw increased harm in that particular trial. We kind of steer away from some of those more strict A1Cs. At least I do personally. I think Cole agrees. But then they also had studies like the advanced trial. They did VADT. They did UKPDS. They did several studies, and they basically saw that maybe some microvascular complications can be reduced as far as the risk, but macrovascular in regards to MI, stroke, things like that, those are not
the important
different.
things.
Yeah,
Things that kill you.
and those are not reduced with lower A1C goals. And I think the type 1 study that they did, like the DCCT and the EDIC trial, I want to say it was almost 20 years before you truly saw a benefit from having the lower A1C goals.
Like below 6.5-ish, right?
So it's one of those things, if you have a much younger patient, maybe in that case it'd be reasonable. But if you're dealing with somebody who's in their 50s, 60s, comorbidities, I personally don't like to push them that low.
No.
But that's just me.
But as far as hypoglycemia goes, they did add in a little blurb that the occurrence and risk for hypoglycemia should be reviewed at every encounter and investigated when need be. Though I would feel that would be common sense. I guess they just threw that in there for completeness sake.
Yeah.
But speaking of Accord, they had some wonky things in here about blood pressure, and they reference Accord, right? What you looking at?
So they basically say, Cole caught me in a sip of my drink. I've been trying not to chew ice this podcast. But
That's why I use a straw. If you use a straw, you're not going to chew any ice.
that's a good call.
It's also better for your teeth if you're drinking like dark drinks like soda or coffee or whatever.
Luckily for me, my sugar-free Monster that I drink 24/7 is
Perfect.
clear
and sugar-free.
and sugar-free, so it's extra healthy. So blood pressure and goals in diabetes. So they basically say that if a patient's ASCVD risk, so using that traditional ASCVD calculator, they say that if the patient's ASCVD risk is greater than 15% or 15% or greater, then they want you to basically push them to a goal of 130/80. And then if it's less than 15, so they don't have as high a risk of having a 10-year event, MI or stroke, then they use the goal of 140/90. So where does that come from? The trial that they actually quote is the Accord trial again. Because if you remember back in 2017, that sprint trial came out, and that kind of caused a big shift in the guidelines from where they had JNC 8. They shifted it with the new American Heart Association guidelines to lower and make more strict the blood pressure goals. The problem is everybody quotes sprint for that change, but the problem is that the sprint trial didn't include patients with diabetes. And the reason for that is because patients in the Accord trial, they didn't see a difference in the blood pressure arm. So we've already talked about the strict A1C goals. They also were studying blood pressure at the same time. So it was set up to be a 2x2 factorial study, which means that basically a patient was assigned to one of the two A1C groups and then also one of the two blood pressure groups. So at the end of the study, when they were looking at just blood pressure, they did not see a difference in outcomes. They did actually see a difference there was a reduced risk of stroke in the more strict blood pressure group, but that was it. The mortality and all that stuff was the same. So basically they said, okay, well, I guess 140/90 is just as good as a lower blood pressure. And that's kind of what the guidelines are pushing here. But the issue is, because it was a 2x2 factorial study, if you think about it, there's patients that were enrolled that were in the strict A1C goal group as well as the strict blood pressure goal. We know that the lower A1Cs ended up increasing mortality, so much so that they stopped the trial early. So the question becomes, okay, did the patient not see a difference because the benefit was kind of negated based on their lower A1C, and then the hypoglycemia and all that risk was basically taking away from the blood pressure benefit they were getting. They didn't see a difference, and so we would hope the study was powered correctly so that we could not have to worry about type 2 error. So basically, there's a statistical difference, but you don't have enough patients there to detect said difference. but the study was not powered appropriately. And so they didn't meet power. So they didn't have enough patients enrolled. And so we don't technically know if there was truly a difference. And we also, when they kind of looked through the data, and they started taking away the patients who had been in the stricter A1C, and they started looking at the blood pressure goals compared to each other of only the patients who were in the more relaxed A1C, the numbers started getting much closer to significance at that point, which we still obviously wasn't powered correctly. But to me, I think that because of the way the study was kind of set up, they set themselves up for failure with seeing that added benefit of the blood pressure goals.
Right.
So we definitely don't like stricter A1C goals, but I'm not against stricter blood pressure goals as long as the person's not having side effects and things. And if nothing else, we know that we reduce the risk of stroke.
Right. And it makes a little more sense based on what we've seen.
Yeah. So there you go.
Yeah.
That's my long-winded answer to that.
That's the Accord.
The Accord trial. Look it up. If you need like an app or some like summaries, check out. It's not our app, and we don't know these people, but just in case you're thinking I'm plugging, the one I use personally is there's an app called Journal Club.
Well, we're definitely plugging. It's just whether or not we're getting paid to plug.
Yeah, this is just my opinion. But Journal Club, I think it's like $6 or $7 to buy the app, and they have really good summaries that have gone through like multiple steps of verification to make sure the information on there is accurate. But they have a good review of the.
I think they still update it too. It's been around for a while.
They have the DAPA HF trial on there, which just came out somewhat recently.
Hot off the presses.
So they got a lot of good stuff.
So another section that they revised and added a fair amount to is regarding technology and continuous glucose monitoring devices, which I think is pretty interesting because I've had multiple patients because usually when the previous recommendations about the monitoring devices, which now there's a Freestyle Libre. I'm blanking on the other ones, but there's a couple others that are pretty frequently used, and they're not actually super expensive, even if you have to pay out of pocket, but they require prescriptions to use. Usually they would only be covered or be prescribed if they were used in people who have an insulin pump or people who have multiple daily injections of insulin. But I've had people who aren't maybe inject insulin once or even don't inject insulin at all, but are on maybe high-risk medications that are higher risk for hypoglycemia and that sort of thing, or they just like to keep a really close eye on their sugars, which is good for them. And they didn't want to have to be sticking themselves 3 times a day, who've purchased it out of pocket and I think have gotten very good benefit from it. So they've kind of broadened the scope of who they think can benefit from this. So they still say that with those, the multiple daily injections and the insulin pumps are going to get the most benefit, but they mentioned other forms of insulin therapy with a level of evidence C can be beneficial as well. So I think that's pretty good. If I had diabetes and I was taking probably more than one medication, I would get one for myself. So I think that's nice.
Yeah, absolutely. Checking your blood sugar that often, there's no chance I would do that.
Right.
I'd be the most non-adherent patient you've ever seen.
No, I like data, and so if I could, I would totally do it.
You'd be graphing out your
for
A1Cs.
sure. Well,
yeah.
I mean, it does it for you, and you don't even have to buy the you don't have to buy the device anymore. You can use your phone.
You'd be the patient who comes in with like folders and be like, here's my graph.
Oh yeah.
Yeah. That'd be good. Me. That'd be good.
Be great.
My patients don't usually do that.
So yeah, that's super interesting. Then in regards to technology, they talk about digital health technology, and especially in reference to like lifestyle management and prediabetes, but also managing your diabetes in general. So they talk about the options that are online with internet advice and coaching, and how some of it kind of mirrors some of the DPP trials and that sort of thing. My favorite part of this is they say that there's some of these that are FDA approved. The FDA apparently monitors these, some that are clinically validated, digital, usually online health technologies, because they're actually intended to treat or intended to treat a medical or psychological condition. So they call these digital therapeutics, or in quotes, digiceuticals. So I was like, who came up with that name? And I looked at the citation, and it was the ADA, but also in conjunction with the European Association for the Study of Diabetes. So I realized, of course, that was a European who came up with that.
Yeah.
No offense to our friends across the pond.
No, it's pretty clever. I like it. Digiceuticals.
Digiceuticals. So that's like
that's the space we need to be in.
We need to be in digiceuticals.
Yeah, that's way cooler than what we're doing.
So that is the online technologies they have to treat and prevent. But they also mention text messaging and various forms of technology, lifestyle coaching to aid in weight loss and increase physical activity. Yeah, so a lot of good things that you can use to aid in their treatment and kind of leveraging technology towards that. Oh, they also mentioned, because there's concerns about online privacy and stuff, because a lot of people are putting their data, like from their glucose monitors or their medications or whatever it is. And so there's concerns about that. But there are apparently established cloud-based data collection programs. A couple of them are Tidepool and Gluco, two things I've never heard of. But they've been developed that are apparently HIPAA compliant options for you to store your health data.
That's cool.
Yeah.
HIPAA compliant.
Mm-hmm.
You want to jump into some of these treatments?
Sure. What you got?
So, the part that you're probably familiar with, hopefully at this point, is, starting the patients off with metformin. That's kind of like our main agent of choice for type 2 diabetes. And then there's even some patients that will get that as a type 1. You don't really get hardly any A1C benefit from that, but you may get some reduction in cardiovascular events or weight gain, things like that. So maybe. But as far as like type 2 diabetes, metformin's almost always our first line agent unless the patient just can't tolerate it or has some sort of like a contraindication to that drug. But the question always is, okay, if that's not enough, which a lot of patients, especially I feel like the ones that Cole and I see for diabetes, because they're getting referred to us because they're so uncontrolled. I had a patient today that came in to see me that had just metformin on their profile, and their A1C was like a 13. And they were like, can I just keep taking the metformin and stop eating cookies? I'm like, maybe, but that we really would need to use a second agent to kind of jumpstart the process, because those diet changes take a while, and you need to kind of get control of the glucose so your body can handle the amount of sugar and kind of get back on the horse, so to speak. But so the next question is, what are we going to add to it? So the guidelines do a very good job. They've gotten progressively better at kind of breaking up the second agent to add based on comorbidities and whatnot. So the first one is if a patient has any sort of like established ASCVD. So, they've had an MI, they've had some kind of like other coronary artery disease, they've had, maybe like peripheral arterial disease, something like that, then they have established ASCVD. Then if a patient has like ASCVD risk, so like if the patient has is greater than 55 years old and has some kind of like coronary or carotid or lower extremity artery stenosis or any kind of like left ventricular hypertrophy, then those patients would be considered high risk, and the recommended agent is going to be either a GLP-1 that has, and they actually specify, that has proven cardiovascular disease benefit, or an SGLT2 inhibitor with proven cardiovascular disease benefit. So Cole, you want to go through which ones actually, what that means?
Yeah, what does that mean?
You want me to do it?
Yeah, you can do it.
Right on. So as far as all these agents basically had to undergo cardiovascular safety trials. And what they started realizing is that these, not only are they safe, some of these agents actually reduce cardiovascular risk. And so the GLP-1s, the first one we got the data with was Victoza. And so that was like the leader trial. Mm-hmm. And the patients included in that study were pretty high risk for having a cardiovascular event in any way. But we saw that adding Victoza to the regimen decreases that risk. Then some of the other studies, it came out, I think I think it was called Excel was the one for Bydureon.
It didn't turn out that well.
Yeah, unfortunately, they did not have any benefit there. No risk, but no benefit either. And then you had things like the Sustain 6 trial, which was the semaglutide, specifically Ozempic, not the oral semaglutide, but the injectable semaglutide Ozempic. They showed their primary composite was superior, but their study was pretty short, and I think that they're undergoing a longer study currently, or there's at least one in the works. But the one that I like the most as far as cardiovascular outcomes is Trulicity. So the Rewind trial was their cardiovascular outcome, and it was the longest trial as far as, I think it went over 5 years. And also they included like 60 to 70% of the patients that were like not considered like high risk. They were primary prevention patients. They weren't glaringly high risk. And so this is probably the healthiest patient population looked at in these studies, and they still met statistical significance for superiority when you add on Trulicity to patients that have diabetes in their regimen. So I like Trulicity's cardiovascular data probably the best. But all the other agents besides those three, Victoza, the Ozempic, because the semaglutide, the oral version, the Rybelsus, didn't have the cardiovascular benefit from the Pioneer trials, and then Trulicity. Those three injectable GLP-1s are the ones with cardiovascular benefit. For SGLT2s, we have the Invokana, canagliflozin, which was the Canvas trial, and then we have the EMPA-REG outcomes trial with empagliflozin, and then there was the Declare TIMI 30-something trial
32?
for 32, 31, 33, something like that.
It's in the 30s.
Yeah, it was Declare TIMI, I know that, was the dapagliflozin. That one didn't show reduction in mortality, but it did reduce hospitalizations, which is why they went so hard on the heart failure side of things with dapagliflozin.
Right.
Unfortunately, Steglatro, the ortagliflozin, is the new kid on the block. Wah, wah. No benefit whatsoever in any of the categories.
I remember a Farxiga rep before the Farxiga data had come out. I think it was a lunch at a doctor's office, just trying to tell everybody that it was a class benefit. It was after the EMPA-REG had come out, but before Farxiga's data had come out, telling everybody it was a class benefit, and it's like, oh yeah, just use Farxiga, it's fine, it's a class benefit.
It's fine.
Yeah.
Well, that's okay. I had a lunch with the drug. It was a virtual meeting, luckily, but these drug reps were trying to tell me how awesome Steglatro was, and I told myself I'm not going to make a scene. I'm not going to call them on their nonsense. But finally, they just kept going on and on about the same kind of thing, like class effect, and I'm like, it's not, like, you're lying. So finally, I was like, well, the reason why we tend to use Jardiance more is because of the EMPA-REG, blah, blah, blah. I was trying to be nice about it. And then the one guy who claimed to be a pharmacist,
alleged
pharmacist, he's like, he's sitting there and he goes, I don't really know why we get so hung up on like these outcomes. I was like, what did he just say? Because that's the whole point of treating patient. It was ridiculous.
I don't know why we get caught up on these outcomes when there's so much money to be made.
Right. Just stop worrying about which one's better.
Stop worrying about
and just use ours.
Stop worrying about mortality. What does mortality mean anyway?
Right. Who needs to live forever?
Who dies? Whatever.
Who's to say? We're not going to play God. It was ridiculous. It was the most stupid thing I've ever heard in my life. And so I looked at my buddy, who's one of my PA buddies, who was sitting next to me, and he's like, he sees my face, so he started dying laughing. And so these people are trying to like be all professional and give us a thing. And me and him are just like, I gotta go. I can't deal with this anymore.
People may listen to us and think we're pompous. I think back to when we first started the podcast. The Trulicity data hadn't come out yet. I remember us in one of the first couple episodes talking about the Rewind trial, and because we were all big on Victoza at that point, there was no semaglutide. Trulicity's data hadn't come out, and but when it comes out and it looks good, oh well, sure, that's fine. Things are constantly changing.
Yeah, and if we sound like because we've been called narcissistic or whatever the heck people have said before.
Oh, did we?
Yeah, some guys said they're super narcissistic. I was like, so just to be clear, I'm an idiot.
Oh, that was when he took your comment totally out of context.
Yeah, so we're idiots, and especially me, especially I'm an idiot in a lot of different areas. I'm not. This isn't my opinion. I'm literally just reading the data that actual smart people.
We're just doing what other smart people said.
I'm just repeating. I'm like a parrot. I'm just repeating what they said.
Be mad at them if you want to be mad at somebody.
So I'm definitely not. Please don't take this as us being cocky, because we're definitely not. I'm admitting right now, I'm a moron a lot of times.
The whole drug rep thing, which I have to interface with drug reps a lot more in my new job, and a lot of them are super nice and very helpful and stuff. Whenever it's about a drug that I know to be not as good as an alternative, but they're trying to push it. That's when I always get this problem. I get always this bad feeling inside, like, why do we have you guys again? Like, what?
Well, imagine trying to be the one selling that drug.
I know
that would suck.
That's why I hate selling anything. Which I guess we have to sell stuff sometimes in a way, like we have to sell to the patients, like this is good for you, right? But I guess that's different because we know that. But maybe they convince themselves that in some ways it is.
We like for my Trulicity rep, she's fantastic, and I like literally she comes in and she's like, "What do you guys need?" and just gives us whatever we need. Like I have zero interest in like trying to talk to her about the studies because I'm like the studies have been done, they're proven it's effective. Like she's got a sweet job. She gets to promote a drug that really has good data. People are trying to promote these other ones that have no data. It's like, ugh.
Yeah, which I mean, that's what they have to do. I get it. Like,
Yeah.
I don't hold it against them.
Yeah, of course
really,
not.
it's the bigger.
I'd be like the worst at that job.
Oh, I would too.
I'd be like, okay,
I'd be like,
here
so
it is. This
here's
drug
the deal.
sucks.
This is what I need to tell you, but this is.
Yeah, here's the reality. This drug sucks.
Right.
I gotta eat. So like, if you could just like buy like one box, that'd be awesome.
The other guys are way better.
I tried to get a job with them. They said no.
The worst salesman ever.
Yeah, it'd be terrible. I couldn't do it.
It's the same thing with the ads. Like, I don't get the ads.
Yeah.
They just don't make sense to me.
I hear you.
I don't understand it.
So yeah, that was a long story short about the cardiovascular data. But
We're not supposed to get that existential.
yeah, whatever. It's fine. It's our podcast. So now if those two aren't an option for whatever reason, and the patients can't tolerate those for whatever reason, then they basically go from there and they say like you could potentially use a TZD or a DPP-4 inhibitor if the patient is not on a GLP-1. Please do not put a patient on a DPP-4 inhibitor like Januvia if they're already on Victoza or Trulicity or GLP-1. Please don't do that. That makes no sense. Like they're on the same exact pathway. DPP-4 is basically the enzyme that breaks down your natural GLP-1. So when you're injecting a synthetic GLP-1 receptor agonist, it's already like resistant to the effects of your natural DPP-4. Inhibition of that doesn't really provide any additional benefit and causes probably more GI upset and things like that, and a lot more money. Please don't do that. Don't be ridiculous.
Yeah. And they also talk about CKD. So did you already talk about CKD?
Mm-hmm.
Okay.
Yep.
So they also talk about CKD, and we won't go too in depth with it for the sake of time, but it's interesting with heart failure and CKD and cardiovascular outcomes and that sort of thing. They mention to consider these independent of baseline A1C. They just want you to consider one of these medications because they have a separate benefit, which to my mind, I think that is a new... So this algorithm that they have on here is totally different than what we saw in school a few years ago.
Very different.
So if you're a professor listening or somebody who teaches on this, you're probably going to want to update your algorithms because it's totally different. But this is kind of cool because they take all of this independent of A1C or even hypoglycemia, which is an emphasis of a lot of algorithms, which is important, but they just make this separate, which is good. So if they have CKD with albuminuria, then preferably you're going to be on an SGLT2 that has evidence reducing CKD progression. Without albuminuria, then they would need type 2 diabetes plus CKD with a certain GFR, and then you're kind of considering them to be at higher cardiovascular risk. So then you're considering a GLP-1 that has cardiovascular benefit, which we've discussed, or an SGLT2 with cardiovascular benefit. So they need to have that albuminuria for you to want to be straight for the GLP-1 to reduce the risk of CKD progression.
And basically, too, if a patient... kind of keep in mind, if a patient has CKD, depending on where their renal function is, the lower the renal function, the less kind of benefit you're going to have with an SGLT2 inhibitor. However, they are using these now in patients that have CKD that don't even have diabetes. So like these drugs are all being looked at in just CKD patients. It started off with like the Credence trial with Invokana, and basically saw that yes, you lose some of the A1C lowering of abilities of these agents when you give them to someone as their renal function declines. However, the kidney protection, nephroprotection is still there. And so that's why...
Because before they had that data, they would be like, yeah, these are pretty much useless if you have a low GFR. But
exactly.
Now there's a different indication.
And so most of these are approved for like patients that have a creatinine clearance less than 30, I think is what they've almost been pushed down to. But some of the more recent like heart failure and CKD studies that they've done with these agents have, I think the last one with, I think it was the Emperor study with Jardiance, used had a cutoff of 20 for their EGFR. So
I think it was just Emperor renal or something, right?
Well, there's one that was heart failure. Their heart failure study used it down to a creatinine clearance down to 20. I do know that for a fact because I know the DAPA HF was 25, and so we have data in
Jardiance down to 20.
Yeah. So you can be used for it safely in those lower patients. You just probably won't get the same A1C lowering the lower your EGFR goes.
Right.
So also heart failure. If you have a patient that has diabetes plus heart failure, specifically if they have reduced ejection fraction heart failure, then you're going to want to use one of the evidence-based SGLT2 inhibitors. So ideally either from the DAP-HF trial, so dapagliflozin or empagliflozin. And then I can't even remember the Invokana data for that. I don't even know if it's out yet.
I'm not aware.
I'd have to go back and look. But those two for sure have outcome data with those. And I know with the Jardiance, their trial was done in patients that had, I want to say their ejection fraction was like in the 20s on average. So it was like more sick patients. They didn't get quite as good of results as the Farxiga folks did on that one. Because I think like the Farxiga had mortality and other stuff. But both of them have reduction in hospitalizations. But yeah, you're using one of those agents, and it helps with multiple areas, not just as for the diuretic effect, but also there's several different potential mechanisms that, if you're really interested, there's a good study that kind of explains those. But yeah, so those are the three comorbidities they specifically mention.
Right. They say metformin, then if they have one of these, consider this before you even consider A1C, because you can add other things on. So if they don't have one of these high risk conditions, and you're looking for A1C lowering, then there's a couple other things that I want you to consider. So one is hypoglycemia, another is weight, and another is cost. So I think that's pretty dead on. I mean, those are things that we consider when we're choosing diabetes medications if we're not considering comorbidities for the most part. I take some issue with the way they talk about the hypoglycemia, only because they put the four kind of standard classes that you would think of being low risk: DPP4, GLP-1, SGLT2, and TZD, the thiazolidinediones, kind of all together, kind of like you could choose any of those four, but you'd probably have a preference, the main preference being GLP-1, then SGLT2, and then, I don't know, it's a toss-up with the TZD or the DPP4s, but it kind of depends on what's going on. It depends on if you feel like you could, if insulin sensitivity would be beneficial, maybe TZD, and I don't know that I would
if
even
you need
still
to
do the DPP4.
If you decide to give medication and don't want any change to the A1C, give the DPP4 inhibitor.
And you want to spend a lot of money.
Right, then you go straight to DPP4 inhibitors.
Yeah, I mean, they'd probably...
They're very wimpy.
They'd probably end up on insulin before I would do a DPP4.
Yeah. I can't remember the last person that... It was probably somebody who just absolutely refused to be on injections and couldn't...
Well, they should be on no injections, no GLP-1, I guess.
Yeah, and couldn't be... and I think they were already on it as SGLT2, and then they had risk for hypoglycemia. So I think that's when I went to DPP4, and their insurance wouldn't pay for Rybelsus, because I know someone's like, there's an oral GLP.
Right.
So yeah, that was the last person I remember doing that. It's been like once in the past several months.
So yeah, they give those four options, and it's like, if the A1C is still above target, if you can't use this one, then go to this one, then go to this one, go to this one. That's kind of the way it is. But if we're preferencing, it's going to be GLP-1, SGLT2, maybe TZD in certain situations, probably not DPP4. But that kind of brings us to cost. So cost throws a huge hiccup into things, and their preferences with the cost issue is TZD and sulfonylureas. Okay, those are the cheapest ones. Those are still not great options, right? So in a lot of instances, even for uninsured or underinsured patients, if you do some work, you can probably get them on other medications, patient assistance, state assistance that provides medications. Even if you have to refer them out to a different clinic that has access to cheaper drugs or whatever, usually there are some options before just sticking them on a sulfonylurea, because you want them to have the best therapy possible. If all else fails, of course, these are options, and it's better than having their sugars run in the 500s. But we'd like them to be on other things if possible.
So if you're not familiar with some of those programs, one, if you're not sure if one exists, Google, whatever the drug name is, manufacturer, patient assistance. But to give you an example, like Trulicity is very expensive. Even as some of like the FQHCs that have 340B pharmacies, so like where I work, Trulicity is still expensive because we it's much cheaper than at a retail pharmacy, but still more than most people have. And so I had a patient just this week who it's a lower income patient, has no insurance whatsoever, and lives by himself, and he was on glimepiride because they kind of assumed that was the only thing they could get him. I send in his income verification and some other paperwork and a prescription for Trulicity to Lilly, the company that makes Trulicity. They have a company or a program called Lilly Cares. Sent them, he got approved. Now he gets Trulicity for free for a year,
right?
And then they'll renew him at that point if he still is considered low income.
And usually, if it is a brand name medication without a generic, then the company, I mean, almost all the companies have some sort of program like this.
Yeah.
And I think they might be even required to have a program like this or something like that.
Yeah.
I think they get some type of tax breaks, so they get something for it.
Yeah, it's probably to keep people off their back about the ridiculous prices they charge for some of these things.
But usually there is an enrollment form that the patient may need to sign or the doctor may need to sign, and then they might need a letter of financial hardship or just income verification, like Mike said. You fax that in, they get them enrolled, and usually they have case managers that kind of handle that sort of thing. Bada bang, bada boom. We've got them on a good drug for at least a year, and then they should be able to re-up if they need to. So a little extra work, but to get them on better therapy. Good example.
Thank you.
Yeah.
So what about weight gain, or to minimize weight gain or promote weight loss?
Right. And so that's important because we can do both of those things with these drugs, right? So historically, the big issue with insulin is that it causes weight gain, right? And other medications like the older ones were either weight neutral or you gained weight. But the GLP-1s, you can actually get some fair weight loss. Same with SGLT2s. The Victoza is branded as Saxenda. Higher doses of Victoza is branded as Saxenda for weight loss. It's an injectable. So yes, if you are need to minimize weight gain or promote weight loss, then you would want to consider an SGLT2 or a GLP-1. And then if either one of those doesn't work, consider the other. And that's kind of the best options for weight gain or loss. With drug therapy, obviously, promote weight management and physical activity, of course.
So one of the things to keep in mind too, so Saxenda, like Cole said, is the one that's approved right now for weight loss, like the GLP-1 that's approved in patients that don't have diabetes. However, be kind of on the lookout for semaglutide, also getting that, because they just had their Step 4 trial come out somewhat recently. I think the data was finally released in like mid last year, somewhere in there. And they have by far the greatest weight loss benefit of all the GLP-1s.
Oh, yeah?
So it was, check that out. Step 4 was the name of the trial. It'll be a shoe-in as far as getting approved for weight loss. But even the ADA guidelines, they have it listed as far as the amount of weight loss to expect. They say that semaglutide by far is the first, or the top, then liraglutide, Victoza, and then dulaglutide, Trulicity, then exenatide and lixisenatide, which is Adlixin. Most of you probably haven't even heard of that because it's trash. But and that makes sense too, because like liraglutide and dulaglutide were compared head to head, and their A1C lowering was the same in the Award 6 trial, but the weight loss was still better with Victoza. Mm-hmm. So that's where they're getting that rating scale from.
Right.
So yeah, that's be on the lookout for that. So semaglutide most likely will be coming out with the weight loss version at a higher dose. I think it was like 2.4 milligrams was the dose they used.
2.4.
2.4. And then
what kind of weight loss they got?
I don't have it right in front of me.
I remember the
very
Victoza stuff was a few kilograms, maybe 2 or 3, which ends up being like 7 or 8 pounds, just standardly, just without doing anything else. So if it's better, then I imagine it's upwards of 10.
This was like 18% of their weight was lost over 68 weeks.
68 or 628?
68.
68.
Yeah.
That's a long time.
So like a little bit over a year, they lost 17%, 17.4%. I have to pull it up to get the exact numbers, but it was significant.
But it was the best.
Yeah, by far.
So it must be upwards.
It was way more than.
It's probably more than
3
10
kilograms or whatever it was.
Yeah. Wow, it's amazing.
Yeah. So very, very good. So be on the lookout for that. There you go. Let's see. What else have we not talked about as far as injectables? We almost skipped injectables. So if you have a patient who, let's say their A1C is elevated to the point where oral agents are not going to be able to get them down. The ADA guidelines used to say, obviously basal insulin was kind of like the first thing that we would go to. Now, with injectable therapy, on top of, having patients kind of be enrolled in some kind of diabetes education, things like that. They basically say if injectable therapy is needed, consider a GLP-1 in most patients prior to insulin. So when you look at, I've heard this question come up too, like people ask like, well, what kind of A1C lowering would we expect with the GLP-1? Usually the textbook answer is like 1 to 1.5%. Insulin can be like whatever, because insulin doesn't technically have you can reduce it to 0 if you really wanted to. Not advised. But that's speaking from trials that like literally were one kind of short term, and also these patients weren't enrolled in like a diabetes education program and all these things. I've had personally seen patients who, after meeting with me to get their meds switched and then meeting with our dietitian, and then being monitored very closely, I've seen patients go from like a 13, 14% A1C down to literally like a 7 or 8 in 3 months. Like, it's crazy how much of a benefit you can get when you
with
have
just
a
GLP-1.
full, with metformin and Trulicity.
Yeah.
That's usually my go-to combo. And so when you have the whole diabetes education package, you can expect much more. Which I think is why they kind of say
when you have the Corvino Deluxe.
Yeah, basically. So GLP-1's first, and then if GLP-1 is not, maybe they're already on that, or it's, they can't get it for cost reasons or whatever, or you prefer insulin, try to start with basal insulin if you can, and then go from there. From basal, you would add, usually if you needed mealtime insulin on top of that, usually you do the biggest meal first, then add the second biggest, and then the third. Try, if possible, not to go to 3 meals right off the bat. If you try to take someone from 1 injection to 3 injections a day, it's not
4 with basal.
Yeah, exactly. It's not gonna work. That's what I meant. Thank you, Cole. I can't add today. But I've also seen patients who are on 3 injections of prandial insulin, like Novolog, having tons of hypoglycemic events, switch them to Trulicity once a week and completely stop their prandial insulin. A1C is way better.
Yeah.
Because they're not having the hypos anymore, so they're not over-treating, and everything just kind of gets smooth and smooth sailing from there.
Yeah. And people with commercial insurance, so if we're not talking about cost issues, you can get these things covered. Like, it's do a PA. Yep. You can get them covered. It's not like it was 2 years ago.
Yeah. And if you're an insurance company and your preferred GLP-1 is Bydureon, get the heck out of here.
Bydureon B-size.
Get out of here with that nonsense. Inferior. Literally, they spent a bunch of money to prove that they were inferior to Victoza. They have no cardiovascular benefits, and you still prefer them. You need to go to jail.
Well, somebody's
ridiculous. Somebody's getting a kickback at this patient's expense.
Somebody's created a contract, and they're getting that stuff cheap, man.
I hate it. Drives me crazy. I sit there and argue with this PA people, the prior authorization people.
It's just some call person like,
he's like,
I don't know what you're talking about.
This guy's so angry. How dare you? One thing I'll mention too, I don't know if you guys have seen this, but basal insulin. So we know we've had like Lantus forever, and then they came out a few years back with Basaglar. So it wasn't a biosimilar because it's insulin. They have to call it like a follow-on, I think is the technical term for it. But now they have the other one that's insulin glargine now, Semglee.
Oh, yeah.
So that's the one that I know in South Carolina, that's the one that I think First Choice prefers, First Choice Medicaid. So I ended up having to switch a couple people to Semglee this past month because they're all sitting there, Basaglar Atlantis wasn't covered. So, yeah. Throw that out there in case you haven't heard it. There's also, I have to look up the name of it, but there's also a Lispro that's another follow-on as well. I can't remember.
Super ultra fast acting or whatever.
So that was like the Fasipa.
Oh yeah.
But there's a new one that just came out. It's hang on, I'll tell you. Looking stuff up on the podcast. Lamjev.
That's a name. That's we talked about that at one point.
Did we?
Because I remember the stupid name.
That is a very dumb name. Whoever came up with that, shame on you.
Lamjiv?
Something like that. It's L and then yum and Jiv.
Lamjiv. That sounds like something you get in the meat section of Walmart.
Maybe.
One of those things that you don't want to eat. The Lamjiv.
The Lamjiv. Yeah. Take 1 pound of Lamjiv because.
What company was that? That's poor marketing.
Yeah, I don't know.
Trulicity is a nice name.
Yeah.
Lamjiv?
Yeah. Lilly needs to pay us for all this free press, by the way. Man. So if you're a Lilly rep, hook us up. Patients assume I work for them sometimes because I'll be pushing Trulicity and they're like,
right.
Looking at me real suspicious. I'm like, dude, it's just because it's an easy drug. It's not because I'm getting paid. I wish I was getting paid, but I'm not. There you go.
Well, there you go. You can be a drug. You can sell the stuff.
Yeah, if the drug's good, I'll be an amazing salesman. If it sucks, I'm gonna be like, oh, geez, I can't do
Good.
this.
You guys got, you got a little bit of updated guidelines. You got some review, and we've discovered that me and Mike would make terrible salesmen.
Yep. I like how you have to sell them after the episode's over.
Yeah,
Show them that
remember, you did learn something.
Remember, you didn't waste your time entirely over this last hour. We did learn maybe something, maybe not.
It's called summarizing. I'm bringing it all home.
No, that's good.
Yeah.
It's like the teach back method, only different.
Except I taught you and then taught you again.
Yeah. And just explain that I did, in fact, teach you something and you need to be thankful. Man, anything else with this?
That's all I got, man.
Cool. All right, you guys. Thank you so much for listening. I hope that was somewhat helpful. If you have any questions, concerns, comments, whatever, our emails will be in the show notes. You can reach out to us on any of the social media platforms. Shoot me a text directly at the area code 415-943-6116. And then we definitely would look forward to hearing from you. Thank you guys so much for those of you who have subscribed to Patreon. That helps us out tremendously and supports the show. And I hope you guys are enjoying like the lectures and PowerPoint slides and all that good stuff. But yeah, thank you guys so much for listening. Greatly appreciate it. Y'all stay warm. Don't get snowed in. See ya.